Ok, bon, ben, bonjour à tous.
All right, well, hello everyone, and thank you very much for your presence. Thank you very much for this topic that we have selected for today. So, first of all, I believe that we have actually two types of participants and speakers at this table. So, we have even three types. One type for them, this is sobriety, as we call restraint or simplicity, is a type of economic activity, and for some others, probably it's a little bit more difficult because this means less revenue. And probably Bertrand, you are a little bit like a scientific figure in the middle of all of this. So that's very interesting. So we'll start with you, Delphine, if you don't mind. So we can imagine that for you, the sobriety or simplicity is probably, well, part of the economic model because it means less acts, less care that is not necessary, which means that will be less refound, which means that the costs will go down. Yes, indeed. I believe that this sobriety, what we mean by sobriety or restraint, this is a good news for everyone here present, because starting from the beginning of this day, we have been talking about different issues like the aging of population, the sedentarity, but also mental health and chronic diseases and things like that. And we also have this increasing need of care and accompaniment. And we understand that the means do not increase endlessly. So I will not, just to tell you that this restraint, this capacity of mastering the evolution of the costs of health, I believe that this is very good news for every operator in the health sector. Well, not just for the insurances, but also for the healthcare operators. And just before talking about this restraint in terms of the care, there was this topic that we have not mentioned this morning, and this was the environment. We haven't talked about environment at all, whereas I believe that there is a very important link between the environment and all the climate-related problems that we have today and biodiversity-related problems today and the health, because 46,000 deaths that are coming earlier than needed, and all the impact on the health and the pollution and things like that, all of this affects the health immediately. And we could definitely say that, yeah, this is not us, but the industry or the food or the whatever, but this is the impact on the health. And all of these things are probably not mentioned enough, but we are paying now for it, and we will continue paying for it tomorrow and the day after tomorrow, etc., etc. So this restraint is, first of all, the restraint in terms of the care, but also the environmental impact of the healthcare sector. And the project has been established, but also evaluated, and it has seen that it's 8% of the CO2 emissions for the healthcare sector, which means that we still have a lot to cover. And a part of it, 1/3, is for drugs. So I think that it's important for us to think about how, through all these activities that we are carrying out and with the means that we have, how can we contribute to this restraint in terms of the environment, because the link with the health is absolutely crucial here, absolutely important. And then we're also talking about this mitigation. So how, in terms of restraint, we can act on this, because we have the CO2 impact and we can talk about it in a very important way, but also the adaptation of all of our jobs. So how can we adapt in order to take care of the elderly people, because we have a lot of nursing homes. So how can we adapt our ways so that to keep working when we have a major peaks of heat and not just average temperatures. And this is part of our everyday life, and has an impact on all of our jobs. So this restraint and the contribution to the restraint is also an important thing related to the environment. Thank you very much. And it actually is a nice segue to you, Xavier, and to the other participants. So talk about your group briefly and what it means for your group. Yes, hello everyone. I am actually one of the representatives of the building operators. So for me, when I am talking about my sector, which is a sector of the buildings, it's important to talk about the CO2 impact And when we are talking about the management of all the different buildings of real estate, because I'm from the real estate sector, it's important to take it into account because we have approximately 60 million tons of CO2 that are being emitted every single year by all these buildings, real estate that we are managing. And this is quite important. So we are actually understanding that by investing, because that's our important activity, we can basically reduce all of this. And this is one of the goals that is part of the laws, and this is part of the CO2 approach that has been selected by all the legislators. But this is also part of the investments into the real estate, so that's to have the reduction of 20 to 30% of the energy consumption. And this is actually an important saving, but it requires a lot of effort. And this is the second point about the restraint or savings that we're talking about it, because I'm an investor and I'm also looking at different capitals that are related to health and to the real estate sector. And what is important for us in terms of capital is the visibility, but also the safety. And we need for the real estate to be paid for. So all of this, of course, is in terms of looking for savings, looking for restraint or simplicity or moderation or whatever, because whenever we have the real estate that has this taken into account, they will be able to pay for their real estate because, well, these square meters also have an impact on the health. And we basically have this role of challenging all the investment projects. So we have this role, which is the one of finding probably some superficial square meters and trying to find additional savings here, so that to improve the situation, to make it much more sustainable and achieve this goal. So what you would like to say in terms of investment in real estate, you will try to do some buildings that will consume less energy, and this will be more savings, but it also means less square meters for the less quantity of beds in the hospital, because we have a lot of debate here, big hospitals or small hospitals or whatever. Well, yeah, there was a debate, but this debate has been solved a couple of years ago, because we understand that the progress is accelerating and everything is accelerating since COVID, and we understand that it's not necessary for us to keep the patients longer than needed in the hospital, and we are trying to also rebuild and remake probably the buildings that have been created a lot of time ago. So it's like a little bit a technical side here, because some patients were already there, and right now we are transforming absolutely everything. So we have the flows that are within each and every building. So we are focusing all the jobs related to the hospital in smaller spaces, less square meters. And with respect to what I has explained with the sense of this restraint or savings, we also have less charges and less turnover that will be probably made there. But also, this savings will represent the possibility to pay for the real estate. Yeah, so you basically have additional guarantees that people will be able to pay for their real estate. Yes, indeed, this is an important point for us, and this is basically this point related to the savings, the restraint, because thanks to this savings, we are reconstituting something that has even more value finally. So, Bertrand, would you like to go back to all of this? Because you are probably part of the people for who this restraint and this saving represent the less turnover. Well, I would like to tell you that in terms of savings or restraint or sobriety, whatever you call it, it actually goes back to the efficiency, because I believe that we have a lot of possibilities to increase the efficiency. And I believe that we have this important source of efficiency, which is in the best secondary use of the healthcare data that we are producing every single day. I believe that this is an incredible source, not only to take better care of our patients by customizing this care as well, but also to feed into the research and not just to feed into the yesterday's algorithms that we are talking for so many years now by the real life data. And here in France, we actually have this absolutely incredible opportunity, because we have SNDS, which is an incredible source of data, and around of this SNDS, we have many different sources of data production. I have actually learned that we have 250 millions of consultations by general practitioners. So what do we do with this data? How do we use it? Does it serve the community with respect to all the different territories? Because we might have some stocks of data. We have some stocks of hospital-related data, and we also have all these registries, whether these are the registries for the rare diseases or the registries for evaluation of different things. So today, we really have this capacity to have a very good structure of production and sharing of this data. But do we have the rules of access and of chaining of all of this data that is an open data? Because right now we have one of the most complicated systems in Europe, where we have to really pass from this notion of zero risk and precautions to the reflection that will be risk and benefit, or risk versus benefit, and then stimulate the data sharing. For example, and I completely agree with you, we have launched together with Green Data Health the very first tenders that allow us to really chain and link all of this data related to the health with the environmental data. Well, I believe that this is an incredible silo that we have here, because we have SNDS that has health-related data that is very rich, but also we have this silo with environmental data that is incredibly rich, but we have never, ever tried to connect the two. So you will say that this is one of the major stakes in front of us. So we are just starting to build up this ecosystem, but I believe that we have to accelerate. And this will benefit absolutely everyone, to accelerate the structuring of this ecosystem and the sharing of this viral data. Yeah, well, you have asked these questions, but I am actually asking questions today as a moderator, so I'm sending you back this question. So is it done today already? Is it being done? Or do you see some hurdles, probably on behalf of the CNIL or some other partners? I don't know. Yeah, well, just to tell you that one of the partners of these structures that has been created in 2019 is doing just that. This is their role, to organize, to structure, and to help to develop all of this ecosystem and to manage it on every single level. So this is done upstream at the level of HDH, or the, just to explain it, the platforms of the healthcare data, and they have to help with creating all the list of the charges that are necessary for all of this, the technical specifications that are necessary for all of this. So this is an incredible stake, and for now we don't really have a lot of things to work with it. We are organizing the tenders right now so that to create these projects and to structure them, we have launched the very first tenders already with Green Data Health, so that to try and match this environmental data to the health data. So yes, indeed, we have some progress here. Do we have some resistance? Oh yeah. Do we have many resistance? Yes, of course. Do we see the end of this process? I would say probably a little bit. So thank you very much. But before giving the floor to someone else, could you please give us an example of this potential application? Because, well, very often we are looking, well, probably we will look at the differences between these two geographical areas, and we will just say that these differences are not really determined by the health-related problems, but we will probably think that in some places where we have much more care that is being given with respect to some disease, then probably there is some waste here. No, what is really interesting here is that we are actually heading towards the much more customized medicine. Just to give you an example, just look at the DeepSarc. DeepSarc is a study, and this study's goal is to look at the real life and to look at how the sarcoma treatment is being perceived. So they're using the database of the network of the 26 establishments that are treating sarcoma in France. So they have this very specific healthcare data, which is coupled to the SNDS, the source of data as well, with the algorithm. And the idea is very simple, but also very strong, because by taking into account all the differences in reaction of each and every patient, we are looking at how we can improve the treatment. And to give you another example, and this is a screening example, the piece, and this is for the breast cancer. So this is the piece, this is a project that associates the use of mammographic scanner data and the reading of it by the artificial intelligence together with SNDS and the medical healthcare data. And the goal of this project is very strong, to try and determine, with respect to the real life profile of each and every patient and to try and determine who will relapse faster, so that to make sure that the interval between the mammographic scanning will not be always the same for everyone, but for these specific people we would be able to do it earlier. So I actually have many different examples like that, and the very last example, it will actually please you. This is one that has INSEM, but also Météo France, so French weather company, and also the database of the scientific and technical group working in real estate that are studying how the climate variations and heat peaks are influencing the offer of care by taking into account the housing conditions. So these are very, very tangible things that show us that it will be here to improve the efficiency and to customize, but we have to have this open source and we have to share the data, and there's a lot of resistance here. So now, yeah, well, thank you very much. We will come back to this. Now, Delphine, and now it becomes a little bit more complicated because for the pharmaceutical sector, savings probably mean less drugs, less turnover, less volume. Well, even though this is necessary, how do we work with this? Well, the very first thing that I would like to say is that the saving, this restraint, is the question for everyone. And I loved what the previous speakers has said. Nevertheless, we have to move toward it. Now, talking about the drugs, what are we talking about? So first of all is to have this moderation. It means that we have to really make sure that the consumption of each drug is really adapted to the need of the patient and not just be overprescribed or something like that. So just talk to you about the good use, the right use of the drug, because I believe that this is the question where everyone has a role to play, because I believe that this good use means three things. First of all, this has a sanitary impact, then it has the economical impact, and finally it has the ecological impact. And yes, Delphine, I believe that this is crucial. So now the sanitary or the health-related impact of this right use. So the France is no longer the champion at the use of the right use of drugs, and it has been several years that it is so. So this moderation, this restraint is not even there, but it does not mean that it's everywhere the same thing. So in some places there is this overprescription with things that probably have a negative impact for the patients, and these are, for example, the antibiotics that no longer work, and this is the health care problem for future as well. This can also be the problem with some other drugs that people are basically taking every single day, and some drugs will be interacting among them and canceling the effects of one another. So these are basically the effects that you are describing, and this is fundamental for the well-being of the patient, and this is the healthcare impact. So just to give you the figures, so we have 130,000 accidents and incidents like that per year, 2,000 deaths at least that can be avoided, and all of this is due to the drugs. So this is the very first point, the point related to the healthcare, to the sanitary impact, I would say. So we need for it to be efficient. The second aspect, as I have said, is the economical aspect. This misuse will, of course, have additional consultations, additional hospitalization, and so on. And this is huge. So the right use of the drug and the committee of the right use of the drugs evaluate at 30 to 60% of all the different medical incidents that can be avoided if we better consume the drugs. And the third point that is also very important is, of course, the ecological aspect. You have already mentioned it. The figures and the projects are very, very important. So we are all emitting 8% of CO2 in France here as a sector. So, of course, drugs are part of it. So we have to, of course, adopt our tools for the production and consumption and so on, and we have to be very careful here. And, of course, we have to understand that the budget of the drugs will be, in this period of crisis, also constrained. So this is a chance for us to do some additional savings and to see how we can better care for the patients while doing the savings. So this is for the right use. Now, if I can continue, I think it's also very important to see what we're doing at the collective level, because I believe that it's better to care better with less. What does it mean? When we have had these discussions following the Born mission with Land, and I'm part of Land, it was obvious for us that we could no longer continue with this high turnover of the drugs. So we actually had to look at our industry for drugs, and to look at the savings. Where is it possible to do some savings? And we have worked as a committee on the savings, so that to make sure that this right use would be a little bit more developed. And we have worked on three important axes. So first of all, the poly drugs, the antibiotic resistance and the waste as well. And this working group started working really, really quickly. So what was the result? Well, first of all, I hope that you have seen there was this very important public campaign reducing the volume of drugs. Well, this is counterintuitive, of course, but it actually has a lot of echo, and this campaign had a lot of echo in terms of awareness raising. Then we also had this partnership with the family doctors, so that to think about how we can alert them, so that to improve the right use of the drugs. And we have had this campaign with 130,000 general practitioners. We have had this newsletter, then we had also worked with some software so that to make sure that every time when there will be a prescription for someone who is 55 years of age plus, and they will be coming out with a drug, there will be a pop-up on the screen of the doctor so that to alert them and to make them ask themselves the right questions, so that to make sure that the drugs are not incompatible, they will not cancel each other's effect. So what and how they will be taken, so that they have to think about it once again. So we have this software that is here, and on 1.5 million of all the different prescriptions, we have this pop-ups, and they are 250,000 right now. So this is just the beginning, but we continue working on it, and we are also working on the waste for the 2025, and this is also something that is very important. Well, Johnson & Johnson is a lab, and they have a lot of different drugs and new drugs as well. So you have talked about the drugs that are like large-scale drugs, mostly probably generic drugs, or are you saying that probably generic drugs, well, it doesn't matter, we will just make less of them? No, I think that the right use of the drugs is basically about absolutely everyone, because we don't want for a patient to take one drug in addition, one drug that is not needed, or one drug less for important pathologies that they must have. So I believe that this right use is basically something that concerns absolutely everyone. So I will repeat what I have been saying to all of my colleagues, and I believe that everyone here is doing the same thing, because the medical charter for every single person who is coming to the practitioner, the first thing that we must know is the right use of the drugs. This is the very first fundamental thing. And then, depending on the drug, how it will be basically developed and so on, it will basically need some adjustments, but the very beginning is the same for everyone. So now, Frédéric, I would like to go to you, because this is also something that talks about the savings, this restraint, because right now hospitals are also getting the money, and this savings will have an impact on them as well. Well, I would like to tell you that we do not master the prices, so we basically can, we're not the only ones who are affected here, but we cannot fix the prices or master the prices. And this is basically an ambivalent question, because on one hand, the savings for the hospitals mean that, yes, well, it will mean less turnover. But this is also like savings. It means really savings. And when we're talking about CNAB, about this savings, it's very practical, because right now we are saying sobriety instead of saying savings. And this is very practical, because this is a new way of tackling this topic of savings at the hospital. So this is a technique to talk about the savings. So what is important for me is that whenever we are talking about this topic, I think that we have three different ways of tackling it. And this is not just for the hospitals. The very first one is the strategy of the degrowth or decrease, meaning doing less, which means that we will have less turnover and so on. Whenever we're talking about it in other sectors, we're never even having this question of the decrease, because this is something that makes us crazy. Whereas in the hospitals, the decrease is something that we wish for. Well, we are actually thinking about this term, of course, but we know how to do this. We are limiting the number of the doctors. We are also like looking at the evolution of the inflation and so on. We know that this is one of the constraints, but we need to make the hospitals smaller. So this is this decrease that I'm talking about. We haven't done it yet, but this is one of the stakes right now, because we have a lot of expenditure for the drugs and so on, but we haven't really diminished it. But when we're talking about this sobriety, the savings, it means that we are reducing or doing differently. So this decrease, I think that this is not really working, and politically is not really very important, because we can have some growth as well. We cannot really say that we are losing some activity with COVID or losing some beds and so on. We have to relaunch the activity and things like that. And here you will probably say that savings mean less activity at the hospital. But this strategy of the decrease, yeah, why not? But for me, this actually raises a lot of different questions, and these questions go beyond the turnover. But also what is important to understand is that today the hospitals are structurally organized so that to have this increase, have this growth, because otherwise otherwise we won't have any turnover, and it's complicated because we do have a lot of crisis and so on. Let's say a childbirth unit that will not have any growth. This is also very complicated, and when we have a surgeon and the surgeon is not having enough surgeries, the growth is not here, the quantity is not here. So the growth is basically a virtue as well. And in the hospital environment, this is also an important thing. So, you know, growth or decrease, this is quite an important topic here. So the second topic about this growth, probably moderated growth, that we can name it, or something that will be a little bit more reasonable. So all the hospital university centers, they have all of these different initiatives, but we also have this very ambitious plans for the ecology transition on the transport, real estate, the purchases, and so on and so forth. And the hospital is a very important economic activity, and of course, more we are producing, the more we are polluting, and all of this takes our common actions. So we have to avoid the explosion of all of this, because in reality, well, I don't really know, and from the economical point of view, I don't really know all the different measures that allowed us to really have all the savings by reducing the CO2 impact. And the example, just one sector where I believe that it was possible to do it is the energy sector, because yes, indeed, we have created new buildings, we have created the solar energy and so on, but also it must be interesting from the point of view of the economy, because otherwise we are just absorbing what has been done in the past. Well, absorbing is already good, but what I would like to say is that when we're talking about the savings, the sobriety, by doing less, we have to look at the reality and see that this will not be really less. So now, from the economical point of view, there is this topic about the sobriety, the savings, but this is like about the labs, the drugs. But what are we doing in reality? Can we today really affirm that we are working on the relevance of all the different acts, and we will say that we have 300 acts that are useless and so on, and we will just reduce them? Well, we have to prove all of this. At least collectively, we can see that it's very difficult to prove. So very clearly, in this recent growth, the question of relevance is still here, and this is one of the major questions for the hospitals. And today we understand that there is absolutely no economic model that will be basically paying for this relevance for the hospital, right? Yes, of course, we have some reforms that are here, some modifications, amendments, and so on the political level, some probably new laws, but probably, well, they are already ongoing, so probably they will be able to take it all into account, this money bonus for these activities. So how can we do this moderated growth? And of course, all of the actors in the hospital are part of this logics, and they're trying to use different tools in order to achieve all of this. And the third approach is a little bit more complicated, and this is the big transformation. Like, we are looking at everything and we are starting from the scratch. So I will look at the data a little bit later, but we need this data to work with it. But what does it require? It requires first and foremost an investment. And here everyone knows what happens at the level of the national budget and the debt and things like that. And I believe that it's already quite difficult every day to maintain the hospitals that we have here, but to free millions and millions of euros for this very important transformation plan, so that to start everything from the scratch just to talk about energy, I'm not sure that we have this means. So what do? Either we do nothing, or we have to select. And we can have a message here around the ecological transition and the sobriety of the hospitals. If we cannot do everything, we will try to probably divide and do it logically from the point of view of the finances. And I believe that in the upcoming months we will be talking about it, because if we don't have any money, we understand that it will be quite difficult, but we probably also have to question ourselves and to select the most structuring projects in terms of the return of the investment and efficiency and so on. So with respect to the hospitals, probably you can talk a little bit more about this, because I believe that all the hospitals have the same problem. Yeah, well, if you're reasoning about this transformation of the system, and if we're talking at the level of the hospital, so let's say I have a hospital and I have my target. Well, the target is basically not that. The target is the social security, is basically the public budget. So it's not really at the level of one hospital that we're reasoning here. This is why I would like to say that is the global vision of all the hospitals, by saying, let's say we have 10 worst probably buildings or best buildings that have saved that much energy and so on, so that to start, and to look at the investment and to look also at the innovation, because we can definitely see that in all these different plans that we're working on, we have many different topics to work on. Let's say the gas for the anesthesies, and also some products that are very dangerous for the environment that have to be left behind, that we don't have to use anymore. So we have to try and evolve at this level, but also the products that we're using for the cleaning and so on that are dangerous for the environment. Yeah. So from the economic point of view, we don't really know what will come out of it. Yes, that's what I'm saying. It's very difficult to foresee all of this, but this will be financing the buildings of tomorrow. And at minima, I believe that if we can already self-finance or auto-finance all of this, like the renovation, especially like solar energy or energy renovation for the hospital, if we can find these models and do it with our own efforts, this will be absolutely fantastic. So this is one of the approaches that is perfect, and if it works somewhere, we have to duplicate it, to copy it, and to implement it elsewhere. Because in terms of the hospitals, so we have hospitals, but we also have the university hospital centers, CHU as we call them in France, and some other, but this is not really the question. So we have to look at the overall model to see how we can do this prevention at different levels. And this apply this topic of sobriety or savings to the prevention as well, because the hospital is basically suffering from the impact through the patients that they are welcoming, and this is the impact of the environment, the pollution that is being generated, and so on. Well, these are the activities for the hospital, but they are here because there is the patient, because the prevention does not really work, and we do not prevent, and we do not stop this pathology. And this is part of the environmental policy, agriculture, food, and etc., etc., etc. So we have to work on it, but also work on the screening and much more customizable approach to the medicine. And I believe that this is the major source. This is the major source. And yes, of course, this source of saving, this is something that is not done overnight, so it will require a dozen of years or something like that. Thank you so much, Delphine. You would like to react? Yes, indeed. I wanted to go back to this prevention topic because I believe that we have this absolutely incredible field of action in front of us. But when we're talking about this savings, sobriety, the square meters is what we don't really have, but the best treatment is the one that we don't really need. So I think that with respect to this topic, the physical activity, we also have some other non-drug therapies are absolutely fantastic, and it's actually absolutely stunning to see how physical activity, even moderated physical activity, can contribute to a better health of the person, no matter what is their initial state. Because I have looked at this research done by the Montreal University that said that 20 minutes of moderate physical activity does a lot of good and a lot of improvement. And I think that we can basically use this same example by looking at different risks of cardiovascular diseases, risk of diabetes and things like that. I have many topics like that, but the stakes are really high here, and we can see that the impact of the physical activity is incredible. So at the level of all of the society, and we're talking about it to the social partners, companies, employers, by telling them the physical activities in all the different spaces, and especially in the houses, in the apartment complexes, in schools, in places where people hang out, is something to be developed. And this is not a better health in 20 years. This is the better health right now, because these are incidents. These are severe diseases that are being avoided. So just to encourage people, let's say when you are in an apartment complex, to go and do the stairs to go 2 floors up or down, to have this very beautiful staircases so that people would want to go upstairs and downstairs. This is not very expensive, but the benefit of it is absolutely incredible. But, this is something that has to be done at the level of the whole society, focusing on physical activity, and I believe that this is one of the simplest of all the topics related to the prevention. And this is at the level of the whole society. And just to do this small call after your intervention, because you have been talking about the data and the good use of the data, all the insurers are right now fighting to have the access to data, not to do the risk selection or pre-selection, because we're no longer doing it. This is illegal, right? Yes, we're no longer doing it. But the question is that we have some relationship, we have some marketing tools, we have the possibility to do the campaigns. So we will not be replacing the CNAM or different campaigns of public health, but we can add something to it. And if we're doing this screening for mammography and we are able to increase the rate of mammographies of 10 points, just because everyone is deploying their efforts for it, I think this will be much better, because right now we are acting blindly. So we're just looking at the sex and the age, and that's it. So we're not looking at all the other elements that can allow us to probably advise better, to promote better, but probably by using our platforms of accompaniment and just calling people, we will have a better impact. But right now we don't have this personalized data, so that to try and better organize all of these actions with respect to this. So now just to talk about the screening, this is also the refund is also always 100% by the Social Security, right, for the mammography and so on. Yes, indeed. Bertrand, yes. So what I wanted to say is that we're not at all in this culture of efficiency right now, and this is absolutely incredible. We are not in this spirit and in this culture of efficiency, whereas we have a lot of information, and this information can allow us to basically put together some actions that will be very efficient. And it actually goes back to what you were saying about the savings. Do more savings, but also treat more people. And I think that the first step here is the use of the healthcare data. And we actually have this data, but we have a lot of constraints at the national level that are specific to France, that are changing a little bit right now. But I think that the biggest topic here is to say that we all want, because this is in the best interest of the professionals, of the hospital directors, but also of the patients, we have to say all together, we want much more efficient healthcare. I think, do we have some elementary tools for that? I think that we are not far from having that, with the condition that everyone accepts to share this data. Well, this will not be zero risks for the patient protection, but we have to think from this point of view. Well, I'm actually a little bit farther from the health sector, even though I'm a very attentive listener here, but I'm hearing two things that are very interesting for me, because everyone is talking about the savings, the sobriety, and everyone understands that this is very useful for us. So this is the consensus, but how can we reach that? This is the second point, and for me, I actually see two things here. The first is the constraint, and the second one is the decision. So the constraint, it can be a decided one, so it can come from outside, for example, and this is what we can see, let's say, with the cost of energy that increased 1.5 years ago, and all the stakeholders had to do 10% of the savings immediately, and that's what they did. So it is absolutely possible. We can do this. And then we have the decision, and this is something that requires time, because we have talked about the social impact, the economic impact of the investment that is carried out, and so on. When we have the time, we can plan and we can manage, but we actually have to really go to the end of the process. We cannot change the direction all the time. Well, in the real estate, that's what we're doing. Well, we have this specific focus and specific issues to our sector. Of course, we know how to do it in the real estate sector. So I think that we will be able to do it in the other sectors as well. Delphine, up to you. Yes, I actually would like to react to what you have said, that to treat better with less. And we have talked about better, but here we are talking about the therapeutic solutions, and we have some therapeutic solutions that when they are on the market, they can also heal some diseases. So I think that we have to look at different means, the measures, and think about this efficiency that is for better. And the innovation is not always something that is required here. Sometimes it generates efficiency, sometimes no. Frédéric, up to you. Well, just to conclude, well, I believe that, well, we have to explain to some people that they will be earning less money. Some institutions or some establishments will probably close and so on. Well, it's not like I'm pessimistic, but I have never seen a different situation. But I believe that if we can have some margins, so what is this margin used for? So right now, I believe that there is this consensus around the margins, and the margins are here to invest into the innovation. But probably we have to invest into the thermic innovation or some other type of innovation. So we actually probably have to debate publicly at what will be the priorities in terms of these investments, because if we can do better with less, I think that we're actually keeping it for ourselves in most cases, and this is not something that goes in the direction of the general interests. Yes, thank you very much. Thank you very much to all of you. Thanks for having participated in this absolutely fantastic debate.